to introduce our moderator for this session, Dr. Nicole Del Castillo. She was most recently a research fellow for the Department of Genetics at Rutgers University. Her work is focused on disadvantaged youth with the goal of reducing disparities and eliminating barriers of stigma, lack of education and access, and preventing minority and underserved patients from receiving needed mental health services. Also, very important to acknowledge is that she is a recent alum of the Commonwealth Fund Mongan Fellowship in Minority Health Policy. And as with my theme of the day, I asked her who her favorite teacher was when she was growing up. And her answer was interesting because she said it was her mother. Her mother is a teacher and introduced the importance of learning at a very early age and introduced her to the classroom setting at an early age as well. So with that, I'd like to bring up Dr. Del Castillo.
Hello. Good afternoon. Thank you all for sticking with us throughout this day. Yes, my mother is an educator, spent very many summers with her, helping set up her room and different things like that. So it was very nice to hear from the previous panel about different educational programs and interventions that are being implemented by communities and school districts and educators. Our next panel will be looking at the role of pediatricians and health providers and community health centers in education. We have an opportunity now to hear about how different health professionals and health centers can be involved in education and why it is important. First, we will hear from Dianne Curtin, followed by Dr. Harwood Egan. Dianne Curtin is the Vice President of Child and Family Services at the Dimmick Center, a community institution providing Boston's Roxbury, Dorchester, and Jamaica Plain neighborhoods. As the second largest health center in Boston, Dimmick is considered a national model of integrated health and human services for the urban community. Under Dianne's leadership, Dimmick provides early Head Start, early intervention, and adult education services for over 100 children and families each year.
I am Dianne Curtin, and as she said, I come from the Dimmick Center. I'm the Vice President of Child and Family Services, and I'm actually a student of Lynette's from years ago. I got my start in social work thanks to her. So I am joining you today to talk a little bit about the Dimmick Center. We are, as was said, we are located in Roxbury. We were founded in 1862 as the New England Hospital for Women and Children. It was the first hospital in the nation that was established by women for women. It was also the first hospital to establish a school for nurses and graduated the first trained nurse in the United States, along with the first black nurse in the United States. So we have a rich history, and we continue today on our 9-acre campus in Roxbury, providing a full continuum of services, which I will play a video for you to just have a sort of a overview of some of what we do. So in general, the Dimmick Center has 3 main program areas. It is our health clinic, our behavioral health services, and child and family services. And within our health services, patients have access to a spectrum of services from adult education, adult medicine, pediatrics, OBGYN, dental, vision, and specialized HIV and AIDS care and support for patients living with that disease. Within our behavioral health services, we have a full array of substance abuse treatment services that begin with detox and move to residential services that are located right on campus, and then outpatient services that are fully integrated into our health clinic, including medical assisted treatment services. Within behavioral health, we also offer a family shelter that's located right on our 9-acre campus, and a home for families who are in recovery in which both male and female children and adults can live, which is a really unique model. And then finally, we have Child and Family Services, which is what I can mostly speak about. And under Child and Family Services, we have Head Start, Early Head Start, a licensed child care, early intervention services, and adult education, all located, again, on campus within 3 buildings. And I'm hoping...
She's calling
okay.
tech support.
So a little bit more then about Child and Family Services. Again, we have on campus every day, we have over 300 children from 3 months to 5 years old. They attend Head Start, Early Head Start, and what we call Foundations for Learning. Those programs run anywhere from 6 hours a day to 10 hours a day, full year. And Head Start is for the school year. We also have in our Early Head Start a home-based program which focuses on expectant mothers and parents who are parenting children 0 to 3 years old. In that option, we have home-based specialists that go out weekly and conduct home visits with the parents and the children for an hour and a half. They also then come on site or into other places in the community where we do socialization groups. That model really focuses on the relationship of the parent and the child and helping to educate the parent on child development and how, as a parent, he or she can engage with their children and really become that first teacher of their child. Early intervention, I think, was spoken about earlier today. Those services are co-located with our Head Start and Early Head Start program, and they provide services for families who have children with either diagnosed or at risk of delays or disabilities. And those services are provided in the community, but also on site. So we have many clinicians who visit children who are then enrolled in our Head Start and Early Head Start classrooms. And it looks like I can now show the video.
As the needs of a community grow with that community, perhaps with the diversity of the community, Dimmick grows with it. Dimmick has kept pace with the needs of the community that it serves.
The relationship between a patient and the first person they meet in the healthcare system is often endemic, and it's important that we nurture that relationship, build trust in that relationship, and deliver good information and good support to that person so that they can get what they need. We hope that the people will come to understand Dimmick as being a friendly institution that wants to help uplift them from whatever problems they may be facing that are healthcare in nature.
I've traveled this country. I haven't seen Dimmicks anywhere else. Major cities, small towns, rural communities. There's not another Dimmick. We need more Dimmicks, and we need to make sure that this Dimmick continues to provide the care and the service that it has provided for over 150 years.
I grew up in the Roxbury community. Over the years, I've grown with Dimmick. My mother brought me to Dimmick when I was 2 years old. I've been a patient here since then. I have a son, and he's 5 years old. And my son goes to Head Start, and I also go to the GD program here. I want my son to know that I want to be an EMT, so you have to study for what you want in life. And they helped me put that knowledge into my son, that you have to work for it.
I have a long history of drug use. I've attempted and tried many times to stop using on my own. I was broken inside. I felt many a times to give in. You know, my mom spoke highly of Dimmick. My first day here, I know I was in the right place. I get the privilege to go home sometimes, to be able to be responsible for my children and to teach them to avoid, some of the things, some of the choices that I made. I have accomplished a great deal here, not only for myself, but for my children.
I knew I needed care, but I wasn't ready to stop getting high. I smoked crack. Smoking crack, cocaine, is one of the worst drugs you can use having HIV. My life just started spiraling out of control. I wanted to stop at that point. Even though I was still using, I wanted to stop. I got sick last year. I got really, really sick. We couldn't figure out what it was. We knew that it wasn't the HIV. I just remember I couldn't breathe. When we found out that it was my heart, they all were here to support me, to let me know that I was important. I don't think these people come to work just because it's a job or it's a career. They do it because they care. They care about us. They care about me, and I know if they care about me, they care about us all. If it wasn't for Dimmick, I wouldn't be where I am today.
You've heard from 3 people who have had different experiences with Dimmick. Experiences which represent just a sample of the comprehensiveness of the care that one can receive at Dimmick. Dimmick makes a difference.
Without the Dimmick Center, he would have it harder. So knowing that going to one place and he can go to school and his doctor's there, we live across the street and it's in the neighborhood, so he feels like it's home.
Without Dimmick, I would probably be in prison. And to be honest, I would have been dead. I'm aware of who I am, and so I've gotten a better sense of who God is and what my purpose is in the community. I will go back to school, get into this field and help someone else to restore.
I've transformed mentally, emotionally, and spiritually. I'm not homeless anymore. I have friends. I am a friend. I was human before, but I'm alive. I'm alive. And it's like, I'm alive. And that's what it is. I'm alive.
I'm proud of Dimmick. I'm proud of Dimmick. I've made a commitment to support Dimmick for the rest of my life. I believe in Dimmick. I believe in Dimmick because Dimmick believed in me.
Okay. So that tells the story better than I do. It is, sorry, there we go. Dimmick really is an absolute amazing organization. I work there, but I've only been there for a year and a half. My experience has been in multiple agencies across the nation. I worked on the West Coast. I've worked up and down in Massachusetts, in early education, in family support, in social work, always focusing on families with young children. And I have not been in an organization that is not single focused on education, that truly is committed to early childhood, that understands the connection of pediatrics and early education, understands that if you have a man that's in a detox and he has a child, that we need to focus on the whole family, that when he moves out, he is going back into his community and with his family. And through early education, we can provide a place to reunite that family and also wash away any stigma that goes along with having gone through substance use treatment. So I say that not because I work at Dimmick, but the breadth of services really allows us to make the change that was talked about earlier and not work in silos. So I'll just continue with Child and Family Services. I've already mentioned that we have Head Start, Early Head Start, a licensed childcare, early intervention services, and then finally in the same building we have an adult education program where we provide classes for families or for adults to prepare for their HiSET or GED. They come into us at minimum at third grade level, and they can stay with us until they complete that HiSET. While they're with us, they also have full access to a computer lab, so they're learning computer skills. Those labs, at the same time those students are in there in the afternoon doing their homework, the teachers from our early childhood program are in that lab with them doing their work. So it's not separate, it's not stigmatized. These are parents of children in our program, along with folks who have been in our detox or our family shelter. And then finally, along with the HiSET preparation, we're really focusing, we're shifting our focus to, that's great, you have a GED, you have a HiSET, but what's next? Because what we know is that with a HiSET or a GED, these families are not going to move out of poverty. So we are really looking at preparing them for the next step and something that will be a career, a path. Sorry. So I think I started to answer that is why early childhood in a community health center? I myself asked myself that as I went to work at Dimmick. I'm sitting around the table with the chief medical officer. Our CEO is a doctor, an MBA. The focus is always on ACOs, healthcare reform, and we're sitting around. There's this pressure, and I'm like, what am I doing here? But the reality is the mission of Dimmick is to heal, uplift individuals, family, and the community. In Dimmick, and we believe that education is the absolute critical tool to do that. Without education, families don't have opportunities. They don't have access. They aren't able to advocate and actually choose their care. So when we talk about healthcare, if families don't have the education, they are not going to be able to navigate the system. So we really see the reciprocal relationship between the medicine and what we call down the hill. Up the hill is the clinic, down the hill is the early childhood center. Up the hill understands what teachers are doing. The teachers understand the importance of helping families get to the doctor's appointments. So just a little bit, I was asked to talk a little bit about Head Start, early Head Start. How many people in the room are familiar with Head Start? Okay, so most people are. So it's as you know, it's a federally funded program. It's a comprehensive school readiness program. And so when we say comprehensive, it's all of the things that were talked about at the last panel, right? It's not just about the child. It's getting the child ready, but it's also about getting the family ready and all of what that means. And then it's working with Boston Public Schools and the other schools in the area and making sure that they are ready for those families and those children when they get there. So we do that, again, in our center-based program and home-based program. I won't repeat that. The three main focus areas of Head Start and Early Head Start are early learning, which I think most in the room understand. It's about providing rich learning experiences for children and engaging their parents in that learning. That it's not about dropping your child off and saying, well, I have 6 hours free and you teach them or you take care of them. But it's really about engaging our families and being part of the program, whether it's coming in and volunteering in the classroom, whether it's helping the teacher, help the teacher prepare an exercise or an activity for the child, to attend classes while you're here, participate in workshops, help us design fun. We just heard about National Week of the Young Child. Help us design fun things like a parade around campus, but really be engaged in the learning that's happening. The next, which is really the place, I think that's the most obvious place for connection with healthcare professionals, is Head Start, Early Head Start has incredible mandates around helping families to ensure that their children remain up to date with preventative care. That's both oral health and mental health, and physical health. So we are required to know that every child, every time they have an immunization, we need to get documentation of that. Every time an infant, who are the doctors in the room? Every time the infants go and have a well child check, we have to have documentation that they went. Because the idea is that Head Start, the educators know that if children are not healthy and they don't have access to health care, they are not going to learn. And so there's an incredible overlap. At Dimmick, we're also, on site, we provide screening, so vision, hearing, developmental screenings. We also have our PD dentist come down into the center and do exams right on site. And then finally, in nutrition, obviously I think that's, for me, goes hand in hand with health. And then finally, family well-being. Every family that comes into our center is assigned a family service worker. That's not to say that they have to work with that person, but they're assigned somebody. They can say, fine, I'm fine, I really just want my child in this program. But 99% of our families work alongside a family service worker who talks to the parent not only about their goal for their children, but what their goal is for themselves, whether it's finishing their education, finding stable housing, or just simply spending some time stress-free with their family. And so our family service workers work with that family throughout their stay with us to move along on those goals. And so what's different, right? Head Start, as you know, is a national program. There's actually other Head Starts across the state here in Massachusetts. There's other Head Start programs in Boston. What I believe are what we call the Dimmick difference is our focus on relationship, our focus on the entire family, our multiple access points for families, and our shared knowledge and resources. And I'll tell you a little bit about this. I think you saw it in the video. I think if you walk anywhere on the Dimmick campus, the number one thing, it doesn't matter if you are in mental health and you're a mental health clinician, you're the person who is conducting the eye test, or you're a coach in our recovery program. Every single person on the Dimmick campus will talk about the relationship that they have with that individual or that family. And what we try to do is leverage that relationship and make sure that if a family starts in early childhood education and we pass them off to the dentist who did the screening, we want to make sure that that family feels that same relationship to our health clinic as they do to our early childhood program. And that's where you heard it in the video, and I am not exaggerating when I say, my second day at Dimmick, I had an all-division meeting with all of my staff for the first time. I was like, okay. And we did an exercise about what does Dimmick mean to you? And I could not believe the number of people who talked about they went to Dimmick when they were a little kid. That my mom took me here. It was like where I went to the doctor. My brother went through the detox. That it was all about the relationship. And then the multiple access points is what is also really unique. So rather than sending the family down the street for their physical, down the street for their education, and then they have to somehow scramble back to pick up their kid at 2 o'clock, it's all right on campus. And then each of our programs really thinks about, again, that whole family. When we interact and a family comes into the program, we think about where can we also connect them? Where's the other connection points on campus or with organizations that we collaborate with? And then shared knowledge and resources. This is where, I was just talking earlier, is I was that early educator and that social worker who was really distant from the medicine field, right? I had great partnerships, but it was really like, at the end of the day, I don't know, go talk to your doctor. I don't know them over there, and I don't know who to refer you to. We have an incredible, since we are under one umbrella, to really share knowledge and resources. So for our head of pediatrics to come down and talk with our staff they come to staff meeting and do trainings for us so that we learn the language of the medicine side, and that they also come to understand what the teachers are doing and why teachers say what they say or do what they do. We share a nurse. So our nurse who works in our child and family services, who the one who goes down to the classroom and because the teacher calls at 9 o'clock in the morning, it's like, this kid has a funky rash and I want him to go home. We send our nurse down and she'll go look, and she's able to, one, a lot of times she knows the child because she works at the health center. So she sees the child when the child goes to their well child visit. But if she doesn't know, she has a direct contact. She can call up the hill. She can text a picture. She can rely, she knows who to call, and it's not calling our outside person that we only call when we have some disease break out in the center and we need to call our medical consultant to say, what do we do? So it's a really great, just amazing ability to share resources and knowledge. And then finally, I think there's many, many opportunities to think about how to build those relationships. Every Head Start around this nation is required to have a health and advisory committee. And what that is we're looking at the community and we're saying, medical people, community folks, come in and help us and make sure that our health and safety procedures and our programs are meeting the needs of the community, are most up to date, make sense, and contribute to the knowledge that we don't have. There are many opportunities to cross programs. We're currently working with our health center mental health consultant who's being trained in a parenting tool. And so rather than child and family and having a teacher or a social worker do it, we're working with our health center and saying, how can we host it in our place, which is really family friendly, and you can send your patients down to us. So I'm happy to talk about many opportunities when it's time for question and answers. Okay, thank you.
Next, we'll be hearing from Dr. Harwood Egan. He is assistant professor at Harvard Medical School in Pediatrics and senior pediatrician at the Department of Pediatrics at Massachusetts General Hospital for Children. Since 1990, Dr. Egan has been the unit chief in pediatrics at MGH Revere Health Center. Dr. Egan has been practicing general pediatrics for over 30 years at Revere, serving a largely underserved community of families, many of which are of diverse ethnic backgrounds. In addition, he has developed a developmental behavioral program designed to create a more accessible and culturally based center for children with a variety of developmental and behavioral needs related to learning, emotional regulation, autism, and other behavioral concerns. Under his leadership, the Revere Pediatrics practice has grown to be a model of intervention and quality care, having been recently designated a certified medical home by the National Committee for Quality Assurance Standards. His expertise and leadership have been instrumental in promoting and advocating for the inclusion of early childhood development in general pediatrics through the unique and successful integration of early child developmental specialists into wild child visits. Current interests include partnerships with the Center for Developmental Child at Harvard University to support and help parents nurture their child's social emotional development within the context of general pediatrics.
But you were going to say
I know.
I don't think I have to talk. And believe me, I wish I didn't right now. Anyway, I won't get too off topic, but let me say, turn this on. Anyway, look, thank you for having me. And even though I am going last, I thought it was supposed to be age before beauty, you know, but. All right, so how does this work? Okay, so let's just start. So I'm supposed to talk about the role of the pediatrician in education, and I will talk a little bit about that. I represent a boots-on-the-ground pediatrician. I'm full-time. I'm not representing the Academy of Pediatrics. This is just what we do at Revere, and I hope it reflects well on what pediatricians are doing all over. But I think we have a couple of programs that I think are innovative and are sort of fun, and maybe we'll tie together some of what you've heard today. But let's start. So I know you need a break, and so let's go to the beach. And for those of you who don't know where Revere is, it's north of Boston, and it's kind of a bedroom community, but it was ranked a few years ago 13th in the state for needs. And so we have a, not as needy a population as maybe other places, but we have a lot of interesting populations there. Okay. On a good day, when I walk in the office, this is what I see. And even on a bad day, I walk in the office and this is what I say. They decided to leave their cell phones at home. So let me start with a story. Not long ago, I was asked to talk about a new community program we were starting in Revere. In the front row, there were important people, including the new young mayor of Revere. I noticed that he seemed quite attentive to what I was saying. At the end, I asked if there were any questions, and he, the mayor, gets up quite excitedly. I thought he was going to give us some money, at which point he points to his ear saying, Dr. Egan, don't you remember me? It's Brian Arrigo, the kid with the chronic ears. This not only proves that I've been in practice a long time, but also that pediatricians can play a very special role in the lives of our patients. Helping a child reach their full potential is without a doubt the passion and goal of every pediatrician I know. Who doesn't love their pediatricians here? Therefore, educational success fits well within the scope of pediatrics. We as pediatricians have a unique position at the interaction of physical, mental, and educational health. Our ability to play an important role is made possible because we often know the child and his family over a very extended period of time. This longitudinal relationship allows us to be a trusted source of information, advice, and connection to the community, specifically the schools. Now let me tell you a different story. Jason was in for a sick visit. I'd known him for a long time. He was now 18, and I always liked him, though he could be difficult. As we were chatting, I asked him how he was doing, as I hadn't seen him for a while. He looked a bit overweight and more tired than you would expect. With a little prompting, he told me he wasn't doing that great. In fact, he'd been in and out of school, mostly out. Never really liked it, found it boring. Presently wasn't doing very much, smoking a lot of weed. He seemed irritable, but not because he was ill. He and his mother had been arguing in the room. I remembered them both very well. His mother was single, recently divorced from an abusive husband, and he was difficult for her as an infant, a toddler, and a very predetermined preschooler. Over the years, he had some counseling for behavioral outbursts, but he was never formally diagnosed with a learning disability or ADHD. Looking at these two situations, it's clear they've had very different developmental trajectories that most likely started early. The first was following a path leading to optimal social-emotional health, along with academic success, entering school ready to learn with appropriate cognitive, social-emotional, and language skills. Social-emotional health. The capacity to feel, express, and regulate emotions, to be empathic and compassionate, to form close and secure relationships, to reflect on yourself and others, to explore the environment and learn. These capacities reflect our highest and most human qualities and are related to educational success and mental health, and this is where we have to keep our eye on. And the second story, more likely a path of social-emotional dysfunction with related physical, school, and behavioral health problems like obesity, smoking, conduct disorders, and substance abuse. So I've had to sadly acknowledge that despite all that we do and our best intentions, children sometimes fail in front of our eyes. We therefore have to ask why and what we might do differently. As everybody here knows, there is no single answer here, but rather the combination and cumulative effect of a variety of risk factors related to the individual, family, peers, and society over a period of time in the extreme, what you call toxic stress. Poor learning, therefore, may be the result of a healthy mind that has become disabled to learn, and our job in pediatrics is often to help unravel this complicated puzzle. So let me review what I think the scope of our role can be. Promoting and monitoring education, along with helping to ensure educational readiness, should be part of overall health maintenance, along with growth, nutrition, and development. Many of our patients have limited educational background and therefore may need a roadmap to creating learning environments for educational success, like less screen time for the child and the parent, and programs like Reach Out and Read and the 5 R's: reading, routines, reward, and relate. Developmental and behavioral surveillance. There should be routine screening at all well visits, like the PSC, the CHAT, the PEDS, and the SWIC. However, any visit is an opportunity to observe and notice if a child's behavior is not age appropriate, sometimes discovering neurodevelopmental problems like self-regulation, language delays, and interactional difficulties. Assess psychosocial stressors. Stress and fear, as all of you know, can make any learning situation more difficult. Children don't exist alone. Pediatricians may have more insight than the schools regarding family and social issues. We know these people for a long time. We often use routine screens like the SEEK as well as the Edinburgh for maternal depression. 4, learning issues are complex. They don't often come into the office saying, I've got a learning problem. They often come in masquerading as somatic complaints like abdominal pain, chest pain, fatigue, headaches, and poor sleeping. Parents often come in with code names like he's lazy or he's bored. Sometimes referrals to neuropsychologists and developmental pediatricians are necessary to better understand these processes like learning disorders and ADHD. Getting information from teachers is of course key as well. And lastly, advocacy. Many of our patients have limited English as well as limited understanding of the educational process. Therefore, we often need to speak with the schools on their behalf to better understand the issues teachers are concerned about. And at other times, parents may feel they've been misunderstood and their children are not getting proper services, and we need to speak for them as well. While pediatricians can and should play a pivotal role, time and expertise remain barriers to our effectiveness with issues like early identification, assessment, and being able to address the variety of needs that challenge our population. Therefore, over the years, our practice has re-engineered itself by integrating other disciplines into primary care. For example, we now have a co-located behavioral outreach team comprised of an outreach worker, a young millennial, and a social worker, very part-time, who can help pediatricians with a variety of issues related to child behavior, school, parental health, parental stress, mental health referrals, and as importantly, concrete services. Take a look at this slide, which reflects the many social issues our families experience. If you were tired looking at this slide, think how overwhelmed I would feel trying to do this. Also think what happens when these social determinants of health and other concerns are not addressed. Let me give you an example. Not long ago, Dr. Diaz saw an 11-year-old patient who came in at the end of the day, which is when they always come in, due to fatigue. Her mother, a Latina woman, also expressed concern, by the way, that her daughter's grades were dropping as she was not completing her homework. The school noticed that she seemed to lack concentration and motivation. It soon became clear that there might be other issues, and in fact, this young girl was very worried that her parents were going to be deported. Dr. Diaz consulted the social worker who happened to be sitting next to her, and they met with the family. They quickly arranged some counseling, added support at school. They even offered some legal counseling. In the end, a medical workup was averted, as well as a mental health referral that often is unwarranted and unwanted. Pediatrics is an ideal, non-stigmatizing place to address these situations and to ensure that their negative impact is minimized through better assessment and a more appropriate and timely targeted intervention. This was the comment that was made to me by a mother of a one-month-old infant when I asked her what were the greatest challenges and fears she was thinking about. I've never heard this expressed this way, but I now know that this is what people think. Every parent has the highest expectations and the best intentions for their children, and our job in pediatrics is to help them achieve their goals, even if there are limitations. Prevention starts early. We know that early social emotional development is a critical part of school readiness and mental health. At the heart of social emotional competence is a healthy parent-child relationship, and every well visit is an opportunity to observe this. So what does this look like? Competent parents create an environment where not only the basic needs are provided for, but in addition they create a space where children can feel listened to, secure, and in control of their emotions. This security leads to a healthy sense of who they are as competent, curious people who are able to explore, play, and learn from their environment. Reflective parenting, according to psychologist Arietta Slade, is the capacity to make meaning of a child's behavior and reflect on the child's experience. So instead of just trying to stop behavior with time out, the parent is able to step back and seek to understand why, moving from reactive to a reflective stance. For many years now, we've had in place a national program called Healthy Steps that is embedded within the practice to help ensure that parents get the right support and advice to create effective parenting environments, and when needed to address the risks that threaten effective and more reflective parenting, like maternal depression and stress. So starting at birth, we assign a child developmental specialist to each first-time mother that is linked to a pediatrician on all well visits from birth to 3. This collaborative model is unique. It allows for a unique relationship between the parent, the specialist, and the physician. The specialists provide a wealth of information regarding how to play with their children, which, by the way, many parents do not know how to do anymore. How to discipline effectively, not punitively, and of course promote early learning through language and reading. In addition, and maybe more importantly, this format helps create an unusual bond of trust through active listening that sometimes allows the parent to disclose private information related to mental health, marital issues, and trauma that is often missed in the typical office encounter and even through the screening. This limits their ability to do reflective parenting, and so it's important for us to find out this information. After age 3, they help to transition children into preschool or Head Start, and if needed, they arrange for further evaluations through our speech and language and development program. To help families that have been identified with more risk, we've integrated a home visiting program called Parent as Teachers for children between birth and kindergarten. The goal is to address social and parental issues in the context of the parent-child relationship. This team is headed by a social worker who meets with each family to help determine what the needs are, and then they're assigned a home visitor. In addition to monthly and sometimes bi-monthly home visits, the home visitor is linked to pediatric visits as well. Referrals are made to community agencies to help with issues like maternal depression, substance abuse, and domestic violence. So in summary, teams make the difference in pediatrics now. We couldn't do this alone. They create time and space to listen, identify concerns before they become problems. They lessen the effects of toxic environments before they create lasting effects. They identify targeted interventions and make referrals. And of course, they do advocacy. So this is what my practice looks like today. We no longer think of ourselves as just pediatricians seeing patients, but rather teams of people who are able to work together to promote education and mental health, as well as address the various medical and non-medical needs of our patients within a medical context. This is the definition of a real medical home. At the bottom is what you would call primary prevention besides healthy steps and the pediatricians. We have a 1,000 Days project that starts prenatally and advances till age 2. We have a father's group. We have a lactation group, and we even have an after-school program for youth. Looking back on what's changed, I have to believe that we may not prevent every case like the one I told you earlier, but there are fewer with earlier and more effective interventions and maybe less severe. So our future goals. Collaboration. I was really struck today that people don't realize that pediatricians and educators have a lot in common, more than you would ever believe, and yet we're often on opposite sides of the fence. We identify kids with problems, and unfortunately the school doesn't always agree. They send the kid to us saying he needs a neurodevelopmental evaluation, which takes 6 months. So we have to develop better communication with our fellow teachers. 2, increased advocacy. The need for legal counsel and advice has increased to ensure the basic needs families are entitled to. We're now trying to get legal advices on staff. Chelsea Health Center, which is a sister health center, already has a lawyer who they consult with. It's unfortunate, but a lot of times, if families don't have legal counsel, they're not going to get the services they need. And 3, innovations. We're currently partnering with the Center for the Developing Child, which is at Harvard, to develop and integrate into general pediatrics more innovative ways to assess parent-child interaction and promote parental reflective capacity. Thank you.
All right. So, I mean, there's so many common themes that you guys both discussed, talking about the importance of teams and relationships, looking at, not only the patient and the health care provider, but, the parent and the child, teachers, health providers, community members, the child, to keeping that in mind. Also, the importance of meeting, families and children where they're at, having the importance of the neighborhood, and also discussing kind of not working just in our own little silos, bringing communities and opportunities and things together. Speaking more specifically, with Dimmick, the educators seem there to really understand the importance of health, and the healthcare providers understand the importance of education. Education, as you mentioned, is seen as a way for opportunities and access for families, as well as Dimmick has kind of kept the pace with the community and realizing the importance of supporting families, the motto of restoring, transforming, and uplifting people. Also, the importance of listening as opposed, or I'm sorry, like I said before, meeting people where they're at in the neighborhood and having all those different services at Dimmick is just very key and very unique. So overall, we just need more Dimmicks around. As far as the pediatrician, they're just really in a unique position, as you mentioned, and they have a unique connection with children and families. The role of the pediatrician to know, they know families over a long period of time, and just really rethinking the roles that pediatricians and health professionals have, such as what you mentioned, promoting and monitoring education, accessing social, psychosocial stressors, developmental and behavioral surveillance, as well as behavioral outreach, recognizing learning issues, and advocating. Because pediatricians are really the ideal place and a non-stigmatizing place to address the social, emotional, and developmental issues that families can have. So I guess we can open up now for questions. Thank you.
So I jumped right up here because I'm a pediatrician from Oakland, California, and everything that both of you talked about are very close to my heart. The preventive role of pediatrics, the importance of partnering with families and bringing supports and early educational supports as well. So my question to both of you is, how do you pay for this all? And how do you keep it funded sustainably, especially apart from grants?
Okay. There's one in every group. Why don't you go first? My answer is shorter.
Yeah, I mean, we do rely, obviously, for the majority of our early education services on federal funding, or obviously early intervention is through insurance or DPH. We do at the same time, we do leverage the opportunity to, if you will, and I probably don't say it the right way, but to sell. It's a model that is unique, and I think it raises, when our fabulous advancement team goes out to sort of court money, if you will, I think the idea that we are unique, that we are serving the whole family, that it's not a model that is singularly funded. So unlike early education in and of itself is difficult because there's a perception that it's the state's responsibility, it's the government's responsibility to educate a child, or it's a parent's responsibility to pay for childcare. I think when you wrap the medical model and the education together, it has people thinking differently.
So, how do you try? Do I need this on?
It's on. Yes.
Oh.
Yeah.
So, it depends which program you meant. So the behavioral outreach one is, I think, very interesting, and I don't take credit for a lot of things, but I do take credit for this. So our behavioral outreach, the woman who does 80% of what you saw up there is 25 years old. She does not have any kind of a background except she's a millennial who's gone to college and she thinks. And it's amazing what these people will do. I mean, they run the health center. The social worker, they work together. So the social worker is only there 8 hours a week. Now, we'd like more, but one of the things is we make sure she's not doing things that this other person can do. So that's how we make that one work, and it's not expensive. I mean, it's actually cheap. There's an army of millennials out there, like AmeriCorps, that are dying to do this, and it's a stepping stone for them to go to. They're not career people. I actually fire them within 2 years. Well, not really, but I kick them out because they have careers. So this is a stepping stone. So that's one. Now, Healthy Steps is more difficult. Initially, we were one of 14 sites that was funded by the Commonwealth Foundation and Partners Healthcare, which is embedded, which Mass General's embedded. So they did support that, but no longer. So we support that internally. 0 to 3, Healthy Steps has now become embedded in the organization 0 to 3. So they're working on this. It feels like there are insurances that will pay for some of their services, but not others. But the cost is not, I think you have to look at the cost in terms of how it changes the dynamics for the pediatrician. If pediatricians remain a beleaguered group of people, they're going to burn out. They need to realize that when someone comes in the room who's addressing many of the issues that they would be taking a lot of time to address or not address, it makes it easier for them to take on more patients. Now, I don't love that model, but if I was the administrator, I would certainly balance the idea as we move towards more accountable care organization. There's going to be more pressure to manage people better. The parent as teachers, we are very lucky. That is a grant through DPH. through the maternal and child health visiting program. And, you know, again, that's a little bit labor intensive because of the model that we have used, which is parent as teacher. So that I don't have a good answer for you.
So it sounds like most of it you're doing basically through your grant, like clinic operational budget,
Yeah.
like through patient billing
So,
and the normal.
no, yes, the Healthy Steps people are built into my budget. Okay. So I could hire a nurse, I could hire a secretary, and I hire 2 of them. Wow. And they own about 800 patients between the 2 of them. And yes, so it's right, it's built in. So we have figured out that it pays for itself. It pays for itself.
I want to talk to you later offline.
Always.
And so thank you both for, you know, your fantastic presentations and, you know, the teams and the collaborations that you have within your organizations. And so I guess my question is, what are the organizational structures that you found that help bring people together from, you know, across these different teams and so forth, making people still feel connected to their patient, keeping people informed, but not having undue, where everybody's just going to meetings all the time. So yeah, I'd love your comments on that.
I'll let you go.
Well, so what I described in that triangle is really true. We all sit together. I mean, we are not in different silos. The only one that's in a slightly different silo at the top, I didn't get into the top, is the mental health. They're kind of down the hall. But everybody else literally sits together. You know, it's kind of like building a kitchen where you need your refrigerator here and your stove here. That's the way it is there. They're one step away from each other, and it makes communication very easy. And we also have a system, now we use Epic. I don't know how many of you have been tortured by this, but the only thing about Epic that I like is it's very easy to communicate to each other. So that's how we make it work. I don't know, does that answer your question?
Yeah, no, that's very helpful. So kind of like physical co-location
and
of the teams.
The other part, just to brief, they need each other. So the reason this works is the pediatricians love these people. They love the social worker. They literally, when I asked them for this, I said, well, tell me what you do for education. And one said, if I get a kid with school problems, I call the social worker. She calls the school. And so they work together very fluidly.
Thank you. I don't know if you had any.
Any other questions? Do we have time for? Got time for one more. Okay. I guess for my question would be, was there any difficulty with some of the cultural, with some of the providers or people within the system with some of these ideas and bringing some of these different models in that might be different from what they're used to, you know, coming into a system where everything is so integrated together and there is this push towards education where, you know, some people are thinking, well, I'm just used to doing what I do and being in my silos. Did you have any pushback with people within your programs and how to kind of work on building those relationships? Or I don't know if you guys noticed any of that.
I think it's both the last question and yours put together. I think there's no pushback. I think that everyone is trying to do the best they can for families, and that when there's opportunity to work together and to build new programs and new interventions, at least at Dimmick, I feel like everyone is on board. I think it comes down to the structure and systems in place to free up the sort of bandwidth or the time to do the work. I also think that, at least for us, one of the biggest challenges is, and goes back to the funding, is the restrictions that the various funding sources put on us. So if, you know, an example is we have early intervention, adult education, and Head Start, all co-located in the same building, serving the same families. In order for the early intervention specialist who works for Dimmick to pick up a child to do therapy in the middle of the day from one of our classrooms and bring them 2 doors down to a different classroom, we have to have separate releases for both programs. We are not allowed to exchange information about what goes on in that time unless we have specific written information permission. So I think I think those are the challenges, and it's at least at Dimmick, I believe everyone has the will to try to integrate as much as we can, but it's the sort of the time to create the workarounds for the system because of the systems and billing and all of that.
For me, so I'm the old dog for sure there, but I'm also the one who knew my background led me to believe for a while that this was the key to pediatrics, and it's also the most fun thing in pediatrics. The cell wasn't very difficult because we didn't do it top down, we did it bottom up. So everybody got trained on this model. And so the buy-in was easy. Plus, a lot of our pediatricians are newly trained. They know this stuff. They come in and they're feeling like, oh my God, I can't let this go. Whereas 30 years ago, I might not want to let it go, but I would have said, well, what can I do? But we don't do that now. We do more now because we can do more now. And I think that's the difference. I think pediatricians need to learn a new language. They need to get out of their silo of, I do a visit and that's it. They need to think more holistically and realize that mental health and behavioral health is part of their thing now. They're not getting away from it. Now, I do not buy the Academy's position on the way they push medicine for ADHD. I think that's not a very smart move because it's not a developmental psychopathological model. It's a real DSM-5 model. And so part of what we're trying to do is train the pediatricians to think social emotionally from the beginning. So the work that we're going to do with Jack Shonkoff's group, everybody knows Jack, but what they're interested in is how you do what they've done in pediatrics. There has never been a practice that's done this. So we've teamed up with this interesting group, and we're going to pilot how you actually create every visit to have a meaning for it. In other words, don't talk just about feeding. Talk about feeding in the context of social emotional development. Keep planting seeds with the parent all along, and then begin to notice which parent is not, I used the word earlier, reflective parenting. I think this is the key. Pediatricians are amazing. They know when they walk in the office after about 4 months if they have the uh-oh factor. And that's the one when they go in and they know the parent's going to be difficult. What they don't know is what they're looking at. They feel it, but they've never been able to conceptualize it. And reflective capacity in the parent is really an interesting paradigm for them to begin to think about, which is, do parents listen? Are they willing to kind of think about and be curious about? So we're kind of working with them to kind of develop this language early on that sort of, I think, will change how they practice.
Thank you.